last but not least, I would like to introduce you your friend and colleague, Dr. Krista Huybrechts, Assistant Professor of Medicine at the Harvard Medical School.
Thank you, Sonia. So it's my pleasure to be here today. And so the previous presentations, we talked about case series, we just heard about registries. So in this last segment, I will talk about like the other approach that has been referred to a number of times, and that is the use of these large healthcare administrative databases. And I'll illustrate some of the concepts that I will be touching upon using an example in the context of opioid use disorder in pregnancy. Before I start, a brief comment about the use of inclusive language. So throughout the presentation, I will use the terms women, mother, and maternal as I focus on the biological sex, but this should really be taken to include people who do not identify as women, but are pregnant or have given birth. So I think most of you are quite familiar with sort of the strengths and the weaknesses of these healthcare utilization databases. So I won't go into a lot of detail, but I just wanted to briefly summarize a couple of the characteristics, specifically focusing then on what is important in the context of drug safety in pregnancy. So importantly, we have information on the exposure before the recording of the outcome. So it's prospective data collection there, which avoids the problem of recall bias. We have information on multiple potential exposures, multiple different outcomes, and we have information on a broad range of clinical factors that can be used for confounding adjustment. And importantly, we're starting from very large source populations. On the flip side, there's also a number of relative weaknesses. So while these data reflect real-world evidence, we're also dealing with a dynamic population. So people come in and out of the population based on their insurance coverage. While the exposure information is based on filled prescriptions, we typically have information on prescriptions on an outpatient basis, not inpatient information. We can conduct validation studies, but typically it's only a subset of the population that we can link to birth certificates, death certificates, or electronic medical records. And while we have information on a range of clinical factors, it's typically with less granularity than you might have available if you collected the data prospectively, like, for example, in the registries that Dr. Cohen was referring to. In addition to that, sometimes, we miss information on some important key characteristics, and an important one is the start of pregnancy. So we have to estimate the start of pregnancy, LMP date, which is the conception date. We have incomplete ascertainment of pregnancy losses, or if the loss occurs before the pregnancy is recognized, obviously we don't have information, but also if the loss sort of happened outside of the medical system. And we're often interested in having some information on laboratory values, like, for example, HbA1c values in the context of diabetes. While we have information on laboratory values, it's often for just a subset of the population. So putting this in the context of sort of where Sonia started, in terms of question of time and question of numbers, those are definitely relative strengths of these data sources. In terms of the methods, as you can see, we're dealing with relative strengths and relative weaknesses. And a lot of the work that is going on in this field is really trying to make sure that we design these studies and analyze these studies in a way that we can capitalize on the strengths, but also then take care and sort of test some of these potential weaknesses. And to a large extent, this really comes down to the trade-off between, and a couple of the previous presenters have been referring to that, like the trade-off between the numbers and having rich information for confounding adjustment, but then also the potential for exposure and outcome misclassification. And as is the case in any non-randomized study, the potential of residual confounding. So moving forward, I will try to touch upon some of these concepts. And as I mentioned, using the example of opioid use disorder in pregnancy. So the prevalence of opioid use disorder during pregnancy has more than quadrupled since the late 1990s. And the current guidelines is for pregnant women with OUD to be treated with opioid agonist treatment for different reasons: to prevent opioid withdrawal symptoms, to reduce the risk of illicit opioid use and illicit use of other substances, and also to reduce the risk of adverse pregnancy outcomes. And currently, we have two treatment options available. On the one hand, methadone, on the other hand, buprenorphine. So methadone is the medication that has traditionally been used during pregnancy. Buprenorphine has become a lot more popular in recent years. A major difference between the two is that methadone is administered through regulated opioid treatment centers, whereas buprenorphine can be prescribed in the outpatient setting by approved providers and can then be self-administered. So back in 2010, actually a randomized controlled trial in pregnant women was published in the New England Journal. And the goal of that trial was to compare methadone with buprenorphine on a range of potential both neonatal and maternal outcomes. And you see the different outcomes that were evaluated in the trial here. This is an excerpt of the table from the trial, but I just want to focus on a couple of them. So in terms of neonatal abstinence syndrome, weight at birth, preterm status, C-section, and medical complications at delivery, what you see is that for all of these outcomes, buprenorphine actually appeared to do better than methadone in the context of this randomized controlled trial. So you see the odds ratio sort of ranging between 0.3 and 0.7. But what I also want to draw your attention to is the width of the confidence interval, right? Whereas they all point to better outcomes for buprenorphine, these effects were estimated very imprecisely because the trial, as is often the case with a randomized controlled trial, was relatively small. So we had 73 methadone-exposed pregnancies and 58 buprenorphine-exposed pregnancies. In addition to the relatively small size, there was differential loss to follow-up in the context of this study. So there was a higher level of discontinuation for the buprenorphine patients compared to the methadone patients. So these trial results were definitely very encouraging, but still left some questions about what is the true magnitude of this effect. So we thought this was actually a great opportunity to sort of make use of these large databases that we have available to see whether we could actually put some more definition around the effects that we observed. So this is exactly what we did. So using the Medicaid data, we looked at the neonatal and maternal outcomes in a large sample of pregnancies exposed to either buprenorphine or methadone. And this is actually work that was led by Liz Suarez, who was a postdoctoral fellow with us at the time, and it was published in the New England Journal last year. And I'll just touch upon some of the highlights. So we started with the mother-infant linked cohort, which was nested in nationwide Medicaid data, and we had data from 2000 to 2018. And for the mothers, we required that they were continuously enrolled from 3 months before the start of pregnancy until 1 month after delivery. For the infants, we required them to be eligible for Medicaid for the first 90 days after birth. And so the reason why we have to impose these eligibility criteria is for the reason that I was referring to earlier. We're dealing with a dynamic population. So a lot of women will actually qualify for Medicaid because of their pregnancy. And if you allow them to enter the cohort at the time, you have this early pregnancy period where you don't have complete information on exposure and potential confounders. In terms of the exposures, so we considered pregnancies exposed if there was a dispensing for buprenorphine or an administration code for methadone needed, because both are administered in a very different way, as I said. And because there is uncertainty about the etiologically relevant time window, we looked at 2 different windows. So early exposure, early pregnancy exposure, and late pregnancy exposure. So early pregnancy exposure being defined as from the start of pregnancy until gestational week 19, and then late pregnancy exposure being gestational week 20 up until the day before the delivery. Because for neonatal abstinence syndrome, we do understand what the etiologically relevant window is there. That window was defined as the 30 days before delivery. Now, in the context of the etiologically relevant window, I do want to highlight that, as what has been mentioned before, like we don't have information on the start of pregnancy in these data sources. So we have to estimate the date of conception, the LNP date. While we have good validated algorithms available, there's always going to be some misestimation. So this is important when we're thinking about defining that etiologically relevant window. We know we'll have some misclassification there that we need to keep in mind when we're interpreting the findings. Going to the numbers, so we start with a cohort of about 2.5 million linked pregnancies. And then depending on what the exposure window is, we had about 10,000 buprenorphine exposed pregnancies and about 5,000 methadone exposed pregnancies. And this is really where these databases shine, right? So compare that to the randomized controlled trial, the mother trial, where we had 58 buprenorphine exposed pregnancies and 73 methadone exposed pregnancies. So moving on to the outcomes. So I mentioned that one of the major advantages of these data sources is that we have information on multiple outcomes. The mother trial looked at a number of different outcomes that are listed here. We can only look at a subset of those. So we can only look at those outcomes that sort of result in a diagnostic code, in a procedure code, or in treatment that is then reflected in claims for reimbursement purposes. So now I list here the subset that we were able to look at. Some of the other outcomes that the mother trial looked at, like for example, APGAR score or maternal weight gain or abnormal fetal presentation during delivery, unfortunately are not the type of outcomes that you can study with these data sources. Then as any non-randomized study, because we don't have the benefit of randomization, we need to take careful control of potential confounding. Here, as I mentioned before, we can sort of take advantage of this rich information on clinical factors that is documented in those data sources. And in the context of this study, we looked at over 70 potential confounding variables. I'm not going to go through all of them in detail, but they're sort of typically classified as like there's the demographic information. Then we try to get a good handle on concomitant medications, comorbid conditions, and then depending on the disease we're looking at, the severity of the disease itself. So in this case, it was the severity of the opioid use disorder, potential complications, history, and so forth. So in terms of the results, I just want to share some of the highlights. And this is a relatively busy graph taken directly from the publication, but I'll orient you to some of the main points I wanted you to take away from this. So on the left side, we have the neonatal outcomes, and on the right side, we have the maternal outcomes. And then for each of these outcomes, we see different estimates. So the different estimates you see there is either depending on the exposure window. So we have the early and the late pregnancy exposure. And then for each of them, 3 estimates: the unadjusted estimate, then the estimate with adjustment for those potential confounders that we as investigators have predefined, and then the third one, an HDPS, high dimensional propensity score adjustment, where we adjust for empirically identified proxies for potential confounding variables. And the first thing I wanted you to take away from looking at this is what you see, that they're all pretty much aligned. So dependent, regardless of the exposure window, regardless of the type of adjustment with it, they're all pretty much consistent. So I'm just going to focus on early pregnancy exposure and then the propensity score adjusted. And what you see when you focus on the neonatal outcomes is that there's a protective effect for buprenorphine with relative risks around 0.6, 0.7. Looking at the maternal outcomes, in essence, we have null findings with a relative risk of 1.02 for cesarean delivery and 0.91 for severe maternal morbidity. The other thing I wanted to draw your attention to is the width of the confidence interval, right? Because we're dealing with these large numbers here, these effect estimates are pretty precisely estimated. But in this study and in any of these studies that are being conducted, I mean, there's really no reason to do adjustment for multiple testing. But we also have to be careful when we interpret these confidence intervals that we don't use them sort of as a replacement for significance testing. We really just want to look at the precision around with which these effects are being estimated. As we said in the beginning, while these data sources have a lot of strength, they also have relative weaknesses. So what we tend to do is really go through a large number of sensitivity analysis to test the robustness of the findings. And I just wanted to give you an example of a couple of the sensitivity analyses that were done in the context of this study. It has been mentioned before, like one of the drawbacks is that we're for the exposure itself, we're relying on filled prescriptions. Filling a prescription is not the same as taking the medication. So one of the things we tend to do in a sensitivity analysis is require to see at least 2 prescriptions being filled. The idea being, if a woman actually goes back to the pharmacy, fills another prescription, pays the copay, she's more likely to have actually taken the medication. And there's a number of sensitivity analyses that are conducted to sort of make sure that we reduce the likelihood of residual confounding. So in this case, we restricted the cohort to individuals with a documented diagnosis of opioid use disorder, even though that we have restricted the exposure to formulations used for OUD treatment and not for pain treatment. But it's again trying to be more specific and try and really get a handle on the confounding. We restricted to states and years when both drugs were covered by Medicaid, and this was done to sort of address any potential geographic or time trends in exposures and outcomes. And then we restricted to individuals who are considered to have excellent prenatal care, which was defined as a high level of prenatal care according to a prenatal care index. And the reason we did this is to make sure that there was no possibility that there was the difference in quality of care between the two groups that could lead to differences in the outcome, and also that there was no differential outcome ascertainment due to differences in the intensity of care that these patients were receiving. And again, what did we find? Similar graph here. The top shows you a neonatal abstinence syndrome, and then the bottom part on the left, we have the early exposure. On the right, we have the late exposure for each of these outcomes. The first estimate is the estimates from the main analyses. The other the ones below it are the sensitivity analysis. And again, here, the main message that I wanted to convey is that regardless of the sensitivity analysis, these estimates are very robust, very consistent. So we know that there's some drawbacks in terms of these data. We can try and test for them and sort of see how that potentially affects the findings. And one potential weakness that has been brought up a couple of times also is like the potential for outcome misclassification, right? In contrast to these registries where there's personal contact with all of the patients that are enrolled and where each of the individual outcomes can actually be adjudicated, we obviously can't do that in a data source with like millions of patients. But what we can do is actually validation studies in a subset of the patient through linkage with the electronic medical records. We can use that to validate the outcome definition and then use the estimate from these validation studies, so the positive predictive value and what we know from prevalence, to correct our relative risk based on these outcome misclassification parameters. And that's exactly what we did here. And it highlighted in yellow here the original estimate, and then in the last column, the estimate corrected for this potential outcome misclassification. And what you see here that it does not explain the protective effect that was observed for buprenorphine. In contrast, actually, correction for outcome classification strengthened the effects slightly. So just as an example of things we can do to try and address some of the weaknesses that are inherent in the data source that we're using here. So to conclude, in any area of drug safety in pregnancy, and then here the opioid epidemic is no exception, there is really an urgent need for data. And as has been discussed, while randomized controlled trials are often like the gold standard in terms of getting at a true causal effect, they're often challenging to conduct in this population. And there was actually a very interesting editorial published earlier this year in the Journal of Pediatrics by Drs. Wagner and Rivera, who actually stated that these large, well-designed forward studies can fill this evidence gap and can actually change practice. And interestingly enough, they actually referred to the study that I just shared with you. But so for us, the conclusion of this study was that actually buprenorphine, just like had been observed in the mother trial, seemed to be associated with better outcomes for the neonates. And to give you a very specific example, so in terms of neonatal abstinence syndrome in the mother trial, they observed a relative risk of 0.7. In our study, we also observed a relative risk of 0.7. The big difference is here that confidence interval, right, where we have much more precision in the present study. But so strong supporting evidence for the results that we found in the mother trial. From a more methodological point of view, this for us was sort of a unique opportunity because we had this randomized control trial and we could use it at the same time as sort of an exercise to see, can we emulate this trial with a well-designed forward study using these large healthcare administrative databases? And in this case, it did. So that really gave us confidence that we could actually then move on to address questions in this context that are not addressed in the context of randomized controlled trials. So we have actually a study that will be appearing in the literature soon, where we looked at the risk of congenital malformations, which, given how rare these are very hard to study, if not impossible, in the context of randomized controlled trials. And we've currently work ongoing looking at these neurodevelopmental disorders, which are also hard in the context of trials because you're really dealing with long-term follow-up. And we're now also looking at different formulations of buprenorphine, comparing the combination product with naloxone, which is available to try and reduce the risk of diversion versus the mono product. So where does this leave us? Like, there's some people out there that really feel that using these healthcare databases to evaluate drug safety in pregnancy are nothing more than a mirage. And then there's this other camp that sort of feels that it's really the next frontier. The truth is probably somewhere in the middle, right? So, and as Sonia sort of started the whole symposium with, and several of the speakers have touched upon, it's not just a question of which data are you using. It's a question of what are the methods that are using, and also obviously what are the numbers. And then, as has been mentioned in the beginning, it's also a question of how do you contextualize the findings? How do you interpret your findings? Because the challenge we're dealing with is really, we want to avoid using any medication that may be harmful during pregnancy, but we have to balance that with the real need to treat medical issues that complicate pregnancies, as Dr. Bowen has been describing. And unfortunately, it is not a yes or no question. It's really about establishing a level of risk and then discussing whether that level of risk is acceptable given the benefits of treatment, given potential other risks that might not have yet been studied. And factors to consider there are definitely uncertainty due to both random as well as systematic error, and that's really what we've been focusing on a lot, but also the safety of therapeutic alternatives, which might include the decision to have to forgo treatment if there's really no other medications available with demonstrated safety. Magnitude of the absolute risk increase, we focused more on the relative risk, but this is really what helps us to sort of establish the public health impact, the severity of the events that we might be observing, and then the perceived benefits of treatment. So I'm going to leave it at that. Thank you.